Good afternoon, everybody. We'll make a start as it's just gone 1 o'clock, and I know the presentation today is going to be full of lots of information that we'll need to give as much of our time as possible to. This is the 8th session of the oncology module run by the BSNR. We've got the previous videos are all online. I'm just going to post the link into the chat box, so if you've missed any of the sessions, the other lectures should be recorded and available there. Today we've got Arpita, who is a consultant in Nottingham, used to be our neuroradiology fellow in Leeds. So it's been a real pleasure to welcome Arpita to the faculty and to hear her speak today. As always, we'll post the PACSBIN cases into the box, and I'll keep posting those in case you have only just turned up, so I'll keep posting that. Use the Q&A box to let us know of any questions. Any other chat, feel free to put it into the chat box. And Arpita, I'll let her explain how she's going to use the PACSBIN cases throughout, but they'll be available in the future as well. So I've got nothing else to say. I'm going to pass you over to Arpita to continue today's session.
Lovely. So thank you very much. So today I'll be talking about paediatric brain tumours, and I'll be concentrating on those in the infratentorial compartment. So why is it important that we consider paediatric brain tumours separately to adults? So we've had some excellent webinars so far. Well, we see different tumours in the paediatric age group, and actually they make up a significant proportion of paediatric malignancy. Following leukemia, it's the second most common malignancy, and it's considered the most common solid malignancy. So whilst this is slightly historic data, it's about 15 years old now, from 2006 to 2008, we're seeing about an average of 400 cases a year. And we see that replicated on other bits of evidence from the literature as well. So again, large proportion of paediatric tumours, and it makes up about 350 to 400 cases on average a year. So what's our role as the radiologist? Well, we've obviously got a key role in the diagnostics of these paediatric brain tumours. We may actually be the first people to identify that there is a tumour there. And through working through the different modalities available to us, the different sequences on MR, we can provide a radiological diagnosis. And by having a really good understanding of these different tumours, we can perhaps even suggest a histological or a molecular diagnosis. We've got an integral role in MDT discussions, so we can work together with the neurosurgeons and help them plan their operations. We can work with the paediatric neuro-oncologists, highlighting where there may be metastatic disease that they need to target with radiotherapy, for example. And on follow-up imaging, we can check for treatment response, any areas of recurrence or residuum that will alter the patient's management. And we also have an important role in research and development and building our specialty and advancing the field. So what modalities are available to us? So we've got ultrasound, but I've not seen ultrasound used either in the diagnosis or the follow-up of paediatric brain tumours. I have, however, seen it used in the obstetric period, and these fetuses often then go on to have fetal MRI, which is where I as a neuroradiologist get involved. So I'm going to show two cases because I've only ever seen two congenital brain tumours. And whilst these aren't posterior fossa, I just want to run through the images. And I'm hoping that these videos behave because they have been a little bit glitchy. So here we go. So this fetus was referred to us not because a tumour was identified, but because the child had bilateral ventricular megaly. And as I scroll through this axial image, you can see that both lateral ventricles are really dilated, and it's asymmetrically so. The right larger than the left. An asymmetrical ventricular megaly, or even ventricular megaly, isn't an unusual referral for fetal MRI, What is unusual, however, is being able to identify a structural cause for the ventricular megaly. And I'll leave it on the axial slice that best demonstrates the tumour, and I'll quickly take you through the coronals. So I'll just let it scroll through once before I scroll through. And here's the coronal. And again, I'll stop on the slice that shows the tumour. And hopefully you'll be able to appreciate that there is an asymmetry. And we've got a really bland looking tumour sat in the region of the right thalamus. So here again, cross-sectional imaging is more superior to ultrasound, and it can really help us find quite subtle tumours. They're not always that subtle. Unfortunately, I've not got the videos for this, but this is a case I saw as a registrar. And it's a really gross congenital tumour where much of the brain parenchyma, both the supra and the infratentorial compartments, have been replaced by this complex solid cystic tumour. There's very little normal brain parenchyma left. We've perhaps got a rind of cerebral hemisphere there on the right. So can be subtle, can be complex, but essentially we've gone to cross-sectional to help us identify the tumours. So next we've got CT, and there is a real reluctance to use CT, and that's understandable because of the radiation dose. But CT really is important in the acute setting, and the big things that CT are good for identifying is whether there's anything that the neurosurgeons need to get acutely involved with. Do the neurosurgeons need to evacuate anything? Do the neurosurgeons need to pop a drone in? And the things that we're looking for are things like hydrocephalus, such as in this case, where we've got really dilated lateral ventricles, periventricular low attenuation, which is suggestive of a degree of CSF migration, and we've lost all of the extraaxial CSF spaces that we would expect to see. So we've got effacement of the convex T sulci overlying both cerebral hemispheres, fullness at the basal systems. And we can see the obstructing tumour sat in the fourth ventricle. CT is also very useful for looking for hemorrhage. So again, we've got a child with quite marked ventricular megaly and loss of the CSF spaces in this case. And as I scroll down to the posterior fossa, we can start seeing hemorrhage in the ventricles. And if I go all the way down, we can see that we've got a hemorrhagic abnormality in the posterior fossa there, with hemorrhage into the extraaxial spaces too. And like on other modalities, we do pick up tumours incidentally on CT. And I say incidental in quotation marks, and I'll show you why in this case. So this is a 7-year-old who presented following a head injury. He was drowsy, he was lethargic, his GCS was up and down. And you can quite clearly see here that there's a huge left-sided extradural hematoma. There's a lot of mass effect associated with it, both subfalcine and uncal herniation. And I've not provided the bone windows, but there was a temporal fracture as well. But as I scroll into the posterior fossa, there's a second abnormality in the midline. Slightly complex, high density in the middle, much higher than blood, similar to the calvarium, so calcification. Got a cystic area over onto the right. And if I scroll towards the left, some more ill-defined, quite diffuse low attenuation on the left. So yes, we did the imaging in the context of head injury, but this is a second finding. And I say incidental because it's difficult to know whether that tumour played a role in the child having a fall in the first place. So is it truly incidental? So essentially, MRI is our preferred modality for imaging paediatric brain tumours. It's got much superior soft tissue resolution. And in the same way that we can use the different modalities, different sequences to identify that following evacuation of that large extradural hematoma, the child's got an acute left PCA territory infarct. So we can see that acutely restricting on the DWI and the ADC, and we've got signal change on the T2. We can use the different sequences to help us build a picture of what the tumour's doing. So this is at the level of the fourth ventricular abnormality. Again, we see that cystic area across to the right. We see a more complex solid area in the midline, which has got calcification in. And we can see that there's no diffusion restriction, but that low attenuation change on the left is shown as quite infiltrative change. So by evaluating all of these sequences and everything else available to us, we can build a picture as to the location of the tumour, what it's infiltrating, whether there's any local or distant metastatic disease. And then we can provide our best radiological diagnosis. So at Nottingham, this is the protocol that we use. I won't go through it, but it's the protocol that's been recommended by the CCLG. There are plenty of professional groups out there that suggest different protocols. Some have even worked towards tailored protocols for each different type of paediatric brain tumour. So they may suggest a certain protocol for medulloblastoma, another for ependymoma, another for high-grade gliomas. But this works well for us. It's very comprehensive, and it means that we've got excellent comparative images for follow-up. There are certain considerations that we need to think about when we're imaging the child, and we don't often think about these in the adult age group. As we all know, to be able to give the best radiological diagnosis, we need still images. And in order to get optimal imaging, we need the patient to be still. Sometimes these scans can take half an hour, 40 minutes. And if we keep adding further sequences, it gets longer and longer. So from birth to about 6 months of age, we can get away with the feed and wrap technique. The babies tend to tolerate that quite well. Between 6 months and up to maybe 6, 7 or 8 years, we're looking at a general anaesthetic. And whilst that might seem the easy option, we'll get still images, it doesn't come without its risks. And actually, it also limits the availability of the scan because it needs anaesthetic support. From 6, 7 to 8 years old, you're looking at considering distraction techniques, teaching the child about what will happen or taking their mind off what will happen. And the play therapists are excellent at this. Recently, we've had a new scanner installed and we've got a little kitten scanner. So when we go inside, it's got a small MRI that the child can come in and play with and understand what might go on when they go into the big scan room for their own scan. There are plenty of patients they can pick and place onto the MR bed and push into the scanner. And on the screen above, it will go through the patient having a scan. So here, I don't know how well it shows, but the chicken's actually got an egg inside. And the story's all about the fairy egg mother. And then what happens is when the child goes into the main scan room for their own scan, this story continues in the on the big screens in there, and they'll be able to watch it in the scanner. So that works as an excellent distraction technique, and it also helps educate them about what will happen. And it's really important that these children have a good experience rather than a traumatic or bad experience, because these children will have frequent follow-up scans in the post-operative or the post-treatment period. Other things from a more imaging or a radiologist point of view is, do we need to consider using techniques such as propeller or blade techniques, which account for any motion artifacts? And do we need to start tailoring the sequences? If we start to see that the child is getting unsettled, do we always need a sweep? Do we always need a flare? Can we change the sequences that the scans are done in? So these are all considerations. We've recently also had our intraoperative MRI installed following a charity drive. And this is what it looks like. We've got a state-of-the-art operating theatre. We've got a trolley which transfers between the operating theatre and the MRI scanner. And we've got a new 3T Philips scanner. And the aim of this is that the child will be operated in this operating theatre. And once the neurosurgeons feel like they've got maximal resection, the child will be slid onto the MR compatible trolley, placed onto the MRI scanner, and they'll have a scan. Whilst that's being done, the surgeons will come and sit with the radiologist in the control room, and the radiologist will provide a hot report. If there's residuum left on that scan, the child comes back and the residuum is re-resected, and the surgeons can use that up-to-date scan to help plan their approach. And perhaps a second trip to MR is required just to check that that residuum's been fully resected. If there's no residuum at the time of the first scan, the operation completes as usual. And the aim of this is to cut an early secondary operation in the next few months following the first one. So let's talk about imaging. As we've heard in all of these oncology talks, and I remember Ibby saying it in the very first one, and it was mentioned last week as well, it's all about the location. So I know we've got a variety of people coming to these webinars, so I'm just going to quickly segment out some anatomy in the posterior fossa and just discuss some tumours that can arise in these areas. So the most cranial part of the brainstem is the midbrain, and the most caudal part is the medulla. And in the midbrain and medulla, we tend to get the low-grade pilocytic astrocytomas, and they have a dorsally exophytic growth pattern in these areas. In between the medulla and the midbrain, we've got the pons, and I've split the pons into a dorsal part and a ventral part. So the dorsal part tends to be where we get the low-grade gliomas, whereas more anteriorly in the ventral pons, we see the higher grade tumours. Then we've got the cerebellar hemispheres on either side. We see pilocytic astrocytomas here, and occasionally we can get certain subgroups of medulloblastoma. And between the cerebellar hemispheres, we've got the vermis. And in the vermis, that's where we see pilocytics arise. In the middle, we've got the fourth ventricle. And the fourth ventricle has a roof, and from the roof, we get the medulloblastomas, and it's got a floor up against the brainstem, and that's where we get the ependymomas come from. Anteriorly, we've got the prepontine cistern and other CSF spaces, and this is a really good space to check for tumour growth. I'm not sure how well this will come through, but I've just coloured in the foramina of Luschka as well, and again, they're really good to check for tumour extension. So I'm going to discuss the four big groups of paediatric brain tumours, and I'll start off with the pilocytic astrocytomas. And like my favourite coffee shop says, there's no X in espresso, there's no S in pilocytic. So it isn't pilocystic, as we often hear people say, it's pilocytic. And that translates to hair cell, and that's these long hair-like projections that we see on the smear. It's the most common tumour of childhood, and they're low-grade tumours, WHO grade 1 tumours. They can sometimes look a little bit more aggressive on imaging. They can have odd enhancement patterns. They can recur after having been resected, and they can even metastasize, but they are considered relatively indolent. Following a full macroscopic resection at surgery, they can be considered cured, and they've got excellent 5-year survival rate, so 95% at 5 years. And here's a macroscopic section that I found on the internet, and it shows that the tumour consists of a large cystic component and an eccentric nodule, which is more solid. And that's what we see on imaging. So we see the cystic component, which is low density, and we see an eccentric nodule. And this is a non-enhanced CT, so it appears isodense. 50% of the tumours occur in the midline, and the other 50% off to either hemisphere. And they can occasionally be slightly heterogeneous. Sometimes they can have calcification, and uncommonly they can bleed. MR is our go-to, as I've said previously. So here we've got a vermian tumour, which has got a solid component, and a cystic component that returns near CSF density within. And we can tell it's based in the vermis and in the parenchyma because the fourth ventricle is pushed anteriorly and it's effaced. So we can tell that this is in the vermis. And here's a textbook appearance of a hemispheric tumour. Again, we've got a large cyst and we've got an eccentrically placed nodule. And importantly, on diffusion-weighted imaging, there's no diffusion restriction. So next, let's talk about enhancement. So the textbook definition is that the solid component shows avid enhancement. So here we go with the midline tumour, as well as the hemispheric one, and this is your textbook definition. Now, we all know in radiology that tumours don't always behave as the textbooks describe. And occasionally, you can see that the cyst wall enhances, like in this example. The tumours itself can be more solid rather than cystic. So they're more solid, and this one shows that there's a really well delineated smooth wall necrotic centre. Or the area of necrosis can be a little bit more irregular, like we see here anteriorly. Occasionally, the cysts can be numerous and really well defined in and amongst a more solid looking tumour. Or the tumour can appear wholly solid and can have quite a cloud-like enhancement pattern. So now I'd like you to look at PACSBIN case 1. So hopefully the links have been shared. So what I won't be doing is I won't be showing the cases myself, only because my presentation is very fragile as it stands, and I fear that if I try and alter to a different screen, it'll stop working. But as part of case 1, there are 4 cases, so 4 different pathologies. And I'd like you to look through these 4 different pathologies and identify which you think is an example of a pilocytic astrocytoma. If you want to drop your answers into the chat box, and in a minute or 2, we'll have a look at the answers. Lovely, so I can see some answers filtering through, so I'll give a couple more seconds, well, about half a minute more, and then we'll have a look at the answers. Super, I'll flick through to the next screen. So actually, the answer was case 3. So I'll go through the other examples, and I've got stills from all of them. So one of the cases, and I can't remember which order I put them in, but one of the cases was actually a hemangioblastoma. And you can tell the way I've described a pilocytic astrocytoma, why this is a real imaging it's a differential for a pilocytic astrocytoma. So it's really important that we've got an approach as to how to differentiate them on imaging. So the first thing to say is this is actually an adult scan. I couldn't find a case of a hemangioblastoma in a child. And that's because hemangioblastomas tend to occur in the older children, adolescents, and young adults, rather than in the very young children, which is where you see your pilocytic astrocytomas. So check your demographics. It's the most common primary brain tumour in the posterior fossa in adults. Other things to consider. The cyst wall in hemangioblastomas shouldn't enhance, but we have seen in the cases that I flicked through earlier that the pilocytic walls can enhance. The mural nodule of the hemangioblastoma will have a peel surface as well, whereas the mural nodule in the pilocytic astrocytoma can occur anywhere. So they're all things to consider. Now, one of the times that you should be considering hemangioblastoma in your differentials is if there's a known familial disorder. So I'll let this quickly scroll through and I'll take you through it slowly. So this is a case of VHL. We know it's VHL, and you can see that there are multiple solid cystic tumours in the posterior fossa there. The other diagnostic clue is they've got bilateral ocular abnormalities, and whilst we don't know exactly what they are, the suspicion is that they're either orbital hemangioblastomas or they are the retinal angiomas that have bled previously. But again, both associated with VHL. This patient also had a right-sided pheochromocytoma, as we see on these fused MIBG images, as well, and unlucky for them, a left-sided renal cell carcinoma on the abdominal MR. The other differentials I had in there in the cases was metastasis. And I, again, really struggled to find a metastatic deposit in the posterior fossa in a child. And I went through 11 years worth of paediatric scans from Nottingham. And so this is an adult case. And in the adults, when we see a posterior fossa lesion, it's most commonly going to be a metastasis. So as you scroll through these images, perhaps you saw the second lesion in the left thalamus. But you often see these as ring-enhancing lesions. And depending on what the primary is, free diffusivity throughout. Compare this with the last case, and this is an example of a posterior fossa abscess, where we've got the diffusion restriction, again, ring enhancing. Other clues for this being an infective process is that we've got a right-sided, a pacification of the right-sided mastoid air spaces. And we've also got altered signal within the sigmoid sinus on the right. And as you scroll through, you should have been able to see that track into the transverse sinus and into the torcular. So that's a long segment of thrombosis. So those are your imaging differentials. I'm quickly going to discuss NF1. I'm not going to spend a lot of time on it because we are due to have a talk on phacomatoses in the next few weeks. But there's an association of pilocytics with NF1, and the other imaging features that you should be looking for are areas of T2 hyperintensity, reflective of the phases, the foci of abnormal signal intensity. They tend to occur in the globus pallidi, as well as in the posterior fossa. So we're seeing areas of T2 hyperintensity, and this is a tumour that I've used in the previous cases. The other area just to be mindful of, and again, I'm not going to spend long talking about it, is the hypothalamic chiasmatic area. And here we've got asymmetry, which is suggestive that there's another mass, another tumour growing there. As I mentioned on the anatomy segmentation slide, you can also get these low-grade tumours within the midbrain. So here is an example of a pilocytic, which is not only grown into the tectal plate, it's essentially replaced the tectal plate. T2 hyperintense, there's no diffusion restriction on the ADC, and they've got a little bit of a bizarre enhancement pattern, but again, can be associated with pilocytics. Here's an example in the medulla, and as I said, they have a dorsally exophytic growth pattern. So on T2, we see it dorsally, very bland on the DWI and the ADC with no evidence of diffusion restriction. And we've got some enhancement at the superior aspect of the tumour there. So that's your pilocytic astrocytomas. Next, I'm going to talk about medulloblastoma. These are the most common malignant tumours of childhood, and they're the second most common after pilocytic astrocytomas. They're embryonal tumours and they are very aggressive. WHO grade 4, and they can be metastatic at presentation. So what do they look like on CT? Well, generally, the majority of these tumours occur in the midline. They're well defined and they're very dense. I might have windowed this image slightly to exaggerate that density, but it's a reflection of the cellularity of the tumour. Occasionally, they can be heterogeneous with areas of calcification and cystic areas or necrotic areas. On MR, we can see that the tumour arises from the roof of the fourth ventricle. On T2, you can see areas of heterogeneity. And sometimes you can see areas of low T2 signal, which will be a reflection of the increased density. The increased density is also shown as diffusion restriction on the DWI images. And enhancement can be variable. So, PAC-SPIN case number 2. So please load up case number 2. It should just be an MRI head. So whilst you're on your acute session, the MR radiographers call up to review this patient scan, and that's not unusual practice. So have a scroll through and decide how you want to act. Are you happy that the scan's done? Are you happy that the patient can come off the scanner? Option A. Option B, there's a tumour on the scan, we need to alert the neurosurgeons. Option C, we need to tell the referrers because they need to do a CT chest abdo-pelvis. Or option D, oh, before the patient comes off the scanner, please can we add on some spinal imaging? So take a minute to look through and we'll discuss the answer in a minute. Super, so I can see some of the answers coming through. So yes, a lot of people have given 2 answers and I think that's the right way. So what I do with the child still on the scanner is I'd complete the spine and then would pick up the phone to the neurosurgeons. And why do we need to do the spine? Well, particularly medulloblastoma, as well as some of the other tumours, have a propensity for CSF dissemination. And it's really common to see metastatic disease at presentation. Textbook definition of the metastatic spread is this sugar coating. So we can see what looks like a light dusting of enhancement along the leptomeningeal surfaces, outlining the cerebellofolia here. You can also get quite nodular deposits. So this is from the case that you've just scrolled through. We've got a big nodule of metastatic disease sat, widening the interpeduncular fossa. It also shows diffusion restriction, and you can also see enhancement outlining the basal systems and the convexity sulci. Can also go into the ventricles. I wonder if you pick these deposits up. Best seen on the DWI actually. On the post-contrast scan, the enhancing choroid seems to mask some of the nodules. And we also have a CIS, which quite nicely outlines the discrete nodule in the left ventricle. And this is why we needed to complete the spine. So this is the same case with the interpeduncular deposit, and you can get dissemination throughout the cord, overlying the spinal cord. It can be fine linear enhancement or it can be nodular. And always make sure that you closely interrogate the sacral cul-de-sac as well, because like in this case, you can see discrete nodules layering dependently in there as well. We don't do it here in Nottingham. I've not seen many centres in the UK do it, but some places even do a DWI of the spine to help pick up some more subtle spinal deposits. A quick mention about MRS with medulloblastomas. A lot of studies have found that there is a peak at about 3.4, which represents a metabolite called taurine, and that is picked up on medulloblastoma scans consistently. Otherwise, it's a tumoral trace. So we've done spectroscopy on previous webinars, but we've got a raised choline, reduced NAA peak. So downwards peak, but also look for a little peak at 3.4. and that may help you add strength to your diagnosis of medulloblastoma. On histology, we've got dense sheets of atypical looking cells. The yellow arrows point to frequent mitotic figures and the red to apoptotic bodies. When stained with synaptophysin, there's an overwhelming neuronal phenotype, and the Ki67 proliferation index is high. So it's a highly proliferating tumour, and that's indicated by these brown nuclei, which are all the proliferating cells. So up until the WHO update in 2016, we were considering medulloblastoma to be a single entity, and we were classifying it as per the different histological subtypes. When the update came out in 2016, it was recognised that medulloblastoma was actually genetically heterogeneous, and it was subdivided into 4 different molecular subgroups, and they each have distinct patient demographics, clinical outcomes, histological features, and imaging phenotypes. And I'll quickly go through those. So the first is the Wnt activated, and an aberration in the pathway in these flies means that they're wingless, which is where the name comes from. These are the least common, but have the best prognosis. And these cells come from the lower rhombic lip. So we see the distribution of these tumours from the lateral recess of the 4th ventricle along towards the CP angle. And again, a nice diagnostic clue that this is a medulloblastoma is that there is diffusion restriction, and it therefore suggests that it's a cellular tumour. Next, we've got sonic hedgehog activated. And these tumours tend to be more over into the hemispheres. Again, important clue is that they, whilst heterogeneous, still have areas of diffusion restriction. Those that aren't Wnt activated or sonic hedgehog activated fall into group 3 and 4, and they're both midline tumours. Group 3 has the worst prognosis, and these are often metastatic at presentation. So the case that you scroll through was an example of a group 3 tumour. And this post-contrast scan shows that we've got fine enhancement over the leptomeningeal surfaces of the posterior fossa, and also we've got enhancement along the 7th and 8th nerve bundles going into the IAMs bilaterally. We've got more fine surface enhancement overlying the spinal cord in this case. And again, we've got a tumoral spectrum. Group 4 is the most common, and again, a midline tumour. A nice imaging clue for a group 4 tumour is that they don't enhance very much. These can also be metastatic at presentation, but less commonly than group 3. Tumoral trace, and we're perhaps seeing a small taurine peak. Medulloblastoma has many familial associations, so there are associations with Li-Fraumeni, Cowden's disease, Gardner's disease, amongst others, Turcot's as well. So here's an example that I saw as a registrar in Leeds. I didn't quite understand how special this case was, but because it was a great case, I downloaded it. So this is the one that I used as an example of Wnt. So we've got the lateral recess tumour, which goes into the CP angle. But as you can see, there are other posterior fossa tumours, all of which show diffusion restriction and enhancement, particularly this large posterior fossa deposit. And actually on resection, this was a sonic hedgehog subtype. So it's likely that there are different molecular subgroups in this example of Gall and Galt's. I won't spend a lot of time on this. Again, you'll cover it in a few weeks, but make sure you check for odontogenic keratocysts. And on CT head, these cases may have dense calcification along the falx. So I'll scroll through that. And it also may extend over the tentorial leaflets as well. So that's medulloblastoma. The third most common tumour are ependymomas. They're glial tumours, WHO group grade 2 to 3, so intermediate. And on macroscopic section, they look like these very soft tumours. They're often tan or grey in colour. They're very well defined and they look quite soft. On histology, whilst uncommon, the pathognomonic finding of these true ependymal rosettes, where we get a halo of cells surrounding an empty lumen. More commonly seen is a perivascular pseudo-rosette. So this is what we're seeing here, but also suggestive that this is ependymoma. On CT, they appear as midline tumours and they're plastic. And by plastic, what I mean is that they tend to extend through all of the foramina. So here we're seeing the tumour extend through the right-sided foramen of Luschka. Even on this slice, we can see that it's quite heterogeneous. There are areas of lower attenuation, some cystic change, some areas of higher attenuation, calcification. And that's better shown on this sagittal slice. And there's, you can see all the speckled calcification more inferiorly. And you see calcification in up to 50% of these cases. They can also hemorrhage. On MR, we see that the tumours are closely related to the floor of the fourth ventricle. And on this axial slice, you can see how closely adherent it is to the brainstem. We see it again on the sagittal images. And again, this sagittal image shows how heterogeneous the tumours can be. Even on T2, we've got areas of high T2 signal, areas of low T2 signal, as well as intermediate signal in between. As we see here again, the same tumour, when looked at on the SWE, shows areas of signal dropout and blooming. So that confirms that there's calcification and hemorrhage within. The diffusion imaging can be variable. So if there are areas of particularly high cellularity in the tumour, they can restrict. And if there's areas of hemorrhage or calcification, that can cause local paramagnetic distortion. So it can look quite bizarre. And following contrast, again, variable heterogeneous enhancement. So on this example, we don't see very much in the way of enhancement, whereas here, you've got quite a fair bit, a moderate amount of enhancement. And this image quite nicely shows how plastic these tumours are. So you can see how it squeezes through the foramen magendie, through the foramen magnum, with a tongue of tissue extending into the upper cervical canal, dorsal to the cord there. These tumours also encase a lot of the important structures. So here we see that there's involvement of the distal left vertebral artery as well as the left pica. And in this position, there was also encasement of all the lower cranial nerves. So resection of this tumour took ages as the surgeons had to carefully dissect away. So, PAC-SPIN case 3. Have a look. So there are 3 separate bits to this. The first you should look through is the presentation scan. And I'll give you this for free. This is an example of an ependymoma. So have a look through this. Scroll through the presentation scan. The next study is a follow-up scan done a year later. Have a look and decide, do you think there's any recurrence on this scan? Answer A, no recurrence. Option B, you can see recurrence in the left CP angle. Option C, you can see nodules through the ventricles. And option D, you can see a nodule sat in the prepontine cistern. And pop your answers into the chat box and I'll give you a minute to look through this. Lovely, we're getting some answers into the chat box. So I'll quickly go to the answer. And yes, you can see ventricular nodules. So after this, I'd like you to go on to the next follow-up. And this is actually, for us, quite a recent scan. So this was done 5 years after his initial presentation. Where can you see recurrence now? So I'll give you for free that we've still got the ventricular nodules, but can you see nodules anywhere else? Again, I'll give you a minute for this case. So we're getting some answers come through into the chat. Excellent. So here's the answer. There's a nodule on this case tucked into the left CP angle. So here is the case for those of you who hadn't been able to see it on PACSPIN. So we've got little nodules sat in the ventricles. We knew about those. But there's a new question as to whether there's any new disease. I find it very difficult to assess on just the T2, and I gave you the T1 with contrast as well, which did help. But a really important sequence in evaluating for nodular recurrence is the CIS. And if I scroll to the left CP angle, we can see quite nicely that there's a really discrete nodule sat in there. And the calipers show that it's a centimetre, so it's sizable. And if we go to a comparative slice on the T2, you can see how difficult it can be to see. There's a lot of artifact in the CSF spaces around it. So when you're doing follow-up, particularly for ependymoma and you're looking for nodules, do consider CIS imaging, because it can be really valuable looking for nodular recurrence. I do an ependymoma MDT every Thursday, and we look at images from around the country, and you'll hear the 4 radiologists that do it always say is, please get a CIS. It really does help to look for recurrence. Ependymoma can also be split into 2 groups in the posterior fossa, and that's group A and group B, depending on the methylation status. So the posterior fossa group A tumours have a worse prognosis and they require intensive therapy. They tend to be the infant ependymomas, and they're tucked off midline into the lateral recess towards the foramen olluschka. Better prognosis in the posterior fossa group B tumours. They're in the midline and they occur in teenagers or the older children. Lovely. So we're going on to our last big group of tumours. So please open case 4, part 1, which should be the CT. Have a scroll through the CT and tell me, where can you see a tumour? And I'll give you 1 minute for this. Perfect, a lot of correct answers coming through. So I'll give you 10 more seconds to have a complete look through it. Fabulous. So yes, the tumour is sat in the pons. So have a look at part 2, which is the MRI for this case. And you'll quite nicely see the tumour on the MR. It's much more conspicuous. And tell me, which of these important mutations is associated with this group of tumours? I've only got 3 options in this case. I was running out. Excellent, a lot of correct answers coming through as well. Grand. So yes, it's the H3K27M mutation. So we're talking about diffuse midline gliomas in this case. These are WHO grade 4 tumours. They're highly malignant and they have a poor prognosis. Often a diagnosis of this is fatal. On CT, sometimes it can be subtle. So this snapshot particularly might suggest that you've got streak artifact coming across from the petrous apices bilaterally. And in neuro, I find that symmetry really helps us. So we can pick out asymmetrical abnormalities quite easily. But when it's a parenchymal abnormality in the midline, it can be a little bit more difficult. So in these cases, I find that reformats can help. And the sagittal view quite nicely shows that there's low attenuation in the pons, and the pons is expanded. Also look for surrogate markers that might suggest that there is a mass there, such as asymmetry of the fourth ventricle. It suggests that there's something creeping into it, giving some mass effect there. So as you saw as you scroll through the MR, these tumours are much easier to see on the MR scan. They return T2 and flare hyperintensity. And you can see on these two T2 images just how expansile and infiltrative the tumours are. They have a ventral growth pattern, so a ventral exophytic growth pattern, and they creep around the basilar artery without constricting it. And eventually that will go all the way anterior to the basilar artery. So that's something to look for. On the diffusion weighted images, we often don't see much in the way of diffusion restriction. And similarly, it can look quite bland on the post-contrast images. And that's really to highlight the fact that despite there being no diffusion restriction or enhancement, it's still a high-grade tumour, even though on radiology it can look quite bland. Again, we've got a tumoral trace on the spectrum and a high myoinositol peak in this case. So do we need a biopsy? Often not, and that's for two reasons really. I think as radiologists, we can be quite certain a lot of the time as to whether this is a diffuse midline glioma or not. The radiology is quite clear-cut most of the time. And secondly, the biopsies don't add much to the overall picture. Rather, it's quite a risky procedure in a risky area. So there's a real reluctance to carry it out. Times you might want to do a biopsy is when perhaps the imaging appearances are unusual or the progression is slightly bizarre. So there's a chance it might not be a diffuse midline glioma. The other times we have done biopsies is for entry onto the BioMedi trial. And here's a biopsy tract, and you've got the T2 gliosis outlining the tract of instrumentation there. When we have got biopsy, we see that there are dense sheets of atypical cells. The key 67 proliferation index is high, and that's all of these brown nuclei. And this is quite important. So we, on this slice, have stained for the product of the H3K27M mutation. So it stains positively. So because the stain's positive, it means that the tumour has that mutation. So in the most recent update, so WHO 2016, these tumours were previously known as DIPGs, and you can probably still hear that used in MDTs. It rolls off the tongue quite easily, but on the most recent update in 2016, that term was replaced. And it was replaced by this term, the diffuse midline glioma, histone H3K27M mutant. So a bit of a mouthful. You can see why people still defer to calling them DIPGs. So 60 to 80% of the tumours have this mutation in the gene for histone H3. And as soon as a tumour has that mutation, it's automatically upgraded to a grade 4 tumour, despite any other, the absence of any morphological features. I'll quickly scoot through these images. So part of the reason it was renamed is because these tumours don't always occur in the pons. So here is as an example in the thalamus. And here is an example that we've seen at Nottingham in the spine. So this proved to be a bit of a diagnostic dilemma for us, a really long segment of heterogeneous abnormality on the T2. The child presented acutely, so we wondered whether it was a bizarre transverse myelitis that had areas of hemorrhage. Could it be a cavernoma that's bled? On the post-contrast scan, we've got areas of enhancement through the spine. So we went back and forth for a while with this, and ultimately it was a tissue diagnosis that confirmed the diagnosis. So this isn't on PACSBIN. These images are so historic, they don't have the DICOMs on our PAC. So I'll quickly scroll through. This is the very last case that I'll show you. So as I scroll through, and I'll just do the T2 and the ADC, I'd like you to pop into the chat box what you think this tumour is. So this is the ADC, and this is the T2. So very heterogeneous looking. So I've also given options and the answer there, sorry. So here are your options, and I'll give you 10 seconds because I did just flash the answer up then. I hope you all get it right now. So this is an ATRT. These are highly aggressive tumours, embryonal, and they tend to occur in the very young children. So as I scroll through the T2 really fast, you would have appreciated the immature myelin status. So that was a really young baby. They can be metastatic at presentation, and they're very similar to medulloblastomas. As part of their diagnostic definition, you need to have the INI1 or the BRG1 genetic alteration. And if you don't have that, then you can't call it an ATRT, you give a more descriptive name. So on MR, you're looking for an off midline heterogeneous tumour, areas of cystic change. The T2 areas can also show really low signal, and those were the ones that were ADC low signal as well, so very cellular. On histology, and I'll be very quick with this, these yellow arrows point out the rhabdoid cells, so they resemble immature muscle cells. Densely packed cells, again, very atypical, high mitotic figures. This is the diagnostic stain for the INI1 alteration. The blue cells are the tumour cells, and the brown ones are the normal native brain cells. So you can see that there's a lot of tumour cells on this slide, therefore confirming it's an ATRT. And a high proliferative index on the Ki67 stain. You can get associations with ATRT, so this isn't the same patient. You'll see that this is an adult, well, a teenager, but we've got a mass in the interpolar region of the right kidney, if it will let me scroll through it. And on the coronal scan, we see that again, and actually the whole of the right kidney is non-functioning. There's no excretion into the collecting system, ureter, or the bladder. So there is associations with renal tumours as well. So 1 minute to go. The WHO 2021 update is expected imminently. When I say imminently, I suspect it's going to come out in the next few weeks, if not the next few months. There's a group called See Impact Now. They have made lots of recommendations, but it's difficult to know how much of that will be taken up by the WHO. I suspect ependymomas will be reclassified, and we'll be moving towards a more molecular and genetic classification approach. So it's important that we've got a really good grasp of radiogenomics. So summary slide. We started off talking about pilocytic astrocytomas, solid cystic tumours, enhancing nodule, but there are variations. Then medulloblastomas, very lobulated tumours. They can be metastatic at presentation, and they're dense tumours, lots of tightly packed cells. Third most common, ependymomas. These are very heterogeneous tumours and very plastic. They go out through the foramina of Luschka and down through the foramen magendi. And the last big group of posterior fossa paediatric tumours are the diffuse midline tumours, gliomas, that are mutant. and they occur in the ventral pons. They're very expansile and infiltrative, and they might be quite bland without diffusion or enhancement. And that's me done. So big thank yous to Simon Payne, who's the neuropathologist who provided all those really beautifully labelled histology slides, and to Donald MacArthur, one of the paediatric neurosurgeons, who helped me with the material for this presentation. And I'm done.
Thanks, Arpita. I think we all are. So that's that was really good whistle-stop tour through the posterior fossa in kids. We've got a couple of questions. I've posted the feedback link in into the chat box. If anybody wants a CPD certificate, follow that and you get that automatically sent. The first question is more of a philosophical one, I think. Any ideas when a congenital tumour is not a congenital tumour? Is there a postnatal cut-off age or any histological features?
Oh, I'm not sure. So commonly when we do see congenital tumours, they tend to be teratomas. I don't know when the cutoff is. I suspect anything that we diagnose on obstetric imaging, we will class as congenital. And then beyond that, I think as if we've not seen it on the fetal scans or the obstetric imaging, if we've only seen it in the paediatric age group, we can call it paediatric or a neonatal tumour.
That's great. And then somebody just wanted a reminder about the sequence for looking for a ependymoma recurrence that you described it as a cyst sequence.
Yeah, they can also be called fiestas.
Yeah, it's just it's a very high resolution steady state scan. It's useful for spinal recurrence as well, isn't it? But that's great. Okay, I think that's all the questions that we've had in. So I'll post the feedback link in the chat box again, and then this time next week, 1 o'clock next week, we've got we're going above the tentorium, so we're looking at supratentorial tumours in kids, and it's Dr. Sina Chattopadhyay from King's in London who will be presenting next week. So thank you very much. Thanks, Arpita.
Thank you.